Hello everyone and welcome to this voiceover PowerPoint for the knee unit. For each pathology, we would like you to have a good understanding of the definition, epidemiology, and etiology of each condition. In the clinic, you'll need a good working knowledge of how a patient with each diagnosis is typically going to present and how you tailor your evaluation to further consider that diagnosis. And finally, what other conditions need to be included in your differential diagnosis of that patient. Moving toward the plan of care, we will discuss intervention strategies and any considerations that are unique for each of these conditions. In this voiceover PowerPoint, we're going to go over some of the background information and epidemiology for several of the most common diagnoses that you are likely to encounter in the clinic. This will free up some time in class to allow us to work through some cases and discuss the clinical applications and intervention strategies, as well as discuss some additional pathologies that you need to be aware of at the knee joint. So you probably realized long ago that we're big fans of categorization to help make a broad range of information easier to understand. In the knee unit, we are primarily going to differentiate between chronic conditions or overuse injuries and acute or traumatic injuries. Within these categories, you can also group similar pathologies by their location, intra or extra-articular, and recall that injuries to the intra-articular structures will usually cause a joint effusion to develop. Knowledge of what potential structures are in the different zones of the knee, whether it's anterior, posterior, medial, or lateral, will also be useful for differential diagnosis of a patient's pain source. Furthermore, the unique aspects of each of these structures is important to differentiate the potential for injury given a specific mechanism of injury. Also, each of these structures has different healing capabilities, which will affect the likelihood of success with rehab versus the need for surgical intervention. Before we jump into the long list of pathologies involved at the knee, I want to recognize that it can seem overwhelming, like herding cats, but my hope is to give you a good understanding of these conditions to serve as a starting point. And then by using case studies and with continued clinical practice, you will begin to see some common patterns that make diagnosis and treatment become much easier with time. So the conditions that we will look at in this unit are again divided into the overuse or repetitive microtrauma category and the acute or traumatic injury categories. Some of them are going to be familiar to you, and we will just dig deeper into the details and nuances of each this semester, but some of these are new to you and rather uncommon in practice, but I want you to at least have some familiarity with them because you may eventually run across them in practice. The diagnoses in red text are the ones that we'll be covering background information of during this voiceover PowerPoint. So osteoarthritis of the knee is becoming more of a prevalent problem with the baby boomers reaching older age and higher rates of obesity among our population. It most commonly presents in patients above the age of 45. But patients who suffered traumatic injury or have had meniscectomies at younger ages may present with OA at younger ages. In this study by Jordan et al., they found that there was a higher incidence of osteoarthritis in older patients and women. It's important to recognize that OA can be of varying severity based upon the amount of joint space narrowing present on radiographs. Although most patients with any degree of OA can be helped with rehab, the prognosis is generally better non-surgically when some joint space is still preserved. Risk factors for developing knee OA are obesity, previous knee trauma, female sex, presence of hand OA, and older age. Another more recent study found joint injury, obesity, and occupations involving a lot of stress to the knees to be related to a higher incidence of OA. And although no research has been able to elucidate why females are more prone to developing knee OA than males to date, one of the areas of research we were just beginning at the knee center I worked at was surrounding the fact that on average females have about 1 to 2 millimeters less of joint space on radiographs, indicating thinner articular cartilage in the medial and lateral compartments. So our hypothesis was that maybe by having less tread on your tires, so to speak, that may lead to this early wear in women compared to men. The typical presentation of a patient with knee OA is pain that is often fairly diffuse and constant in nature, with stiffness that is worse after periods of inactivity. So a lot of times in the morning, the first steps out of bed are pretty painful. Crepitus may also be evident, particularly when the patellofemoral joint is involved, but when severe OA is present in the tibiofemoral joint, crepitus or even audible creaking of the joint may also be apparent. Intermittent joint effusions are often present and often vary based on activity level. A sudden increase in the amount of walking or standing can lead to an increase in the amount of swelling. A Baker cyst, which is a fluid-filled cavity in the popliteal space, is really due to a chronic joint effusion, and it often accompanies knee OA. All of these symptoms lead to difficulty with functional activities, and the increasing stiffness can really make activities such as stepping in and out of a bathtub or exiting a vehicle more and more difficult as time goes on. So categorization is particularly important when it comes to pathologies when we move toward the patellofemoral joint. The first important distinction to make is whether you're dealing with patellofemoral pain or instability, because these are two very different beasts. If it is instability, is it traumatic or atraumatic in nature? And we will discuss this in more detail in the slides ahead and then again during class. Many patients with patellofemoral dysfunction have anatomic factors that predispose them to difficulties in this area. And among these, which you're probably familiar with, are valgus knee alignment, larger Q angle, and subtalar pronation. And the three of these are often interrelated, present sometimes together. Patients with a significant amount of subtalar supination may also be prone to patellofemoral problems, as this can lead to added pressure on the lateral aspect of the patella too. Abnormal degrees of tibial or femoral rotation will also influence the alignment of the patella, and that can also lead to dysfunction. And also muscle imbalances, particularly tightness of the IT band and weakness of the medial quadriceps muscle, can lead to abnormally high pressure on the lateral part of the patellofemoral joint. Patellofemoral pain goes by many names. It is a form of anterior knee pain, but I don't recommend using this name to describe patellofemoral pain because anterior knee pain is really a broad term that would encompass patellar tendinopathy, plica syndrome, and other syndromes. Often, patellofemoral pain begins with altered alignment that places increased stress on the articular surfaces of this joint. After many years of stress with the patella not running centrally down the track, osteoarthritis often develops. In this study by Bowling et al., which was done on 1,500 cadets at the U.S. Naval Academy, females were 2.5 times more likely to develop patellofemoral pain, and the incidence was about 22 out of 1,000 people per year. The cause of patellofemoral joint syndrome can be varied, so the factors for each patient need to be carefully considered in order to treat the underlying cause. Many times, it is a case of overuse on top of pre-existing alignment problems. Some of these may be modifiable with rehab, such as dynamic knee valgus due to proximal weakness, while other causes of malalignment may be more difficult to change non-surgically. So activity modification may be a better approach to avoid positions that place a lot of force through the patellofemoral joint in those patients. Patients suffering instability in the past will be at a higher risk for developing patellofemoral OA if normal alignment is not restored. Much of what you will learn about patellofemoral dysfunction is similar to what you've already learned about shoulder impingement, where intrinsic and extrinsic factors can lead to less than optimal arthrokinematics and movement patterns that can exacerbate the problem further. The intrinsic factors related to patellofemoral joint syndrome are instability, poor alignment, muscle imbalance, and poor mechanics. Extrinsic factors are traumatic injury, chronic overuse, or training errors, either problems with the volume of training or even the specific exercise being done. Patients with patellofemoral problems will not respond well to deep lunges or deep squats in general. Also, open chain exercises at the end range of motion provide difficult for these patients as high joint contact pressures are resultant at this range. Patellofemoral pain is often a diagnosis of exclusion in many ways. Features of it are retropatellar pain with more than one of the following: stair climbing or descending, prolonged sitting, squatting, kneeling, and then also a combination of these with negative findings on exam for ligaments, meniscus, bursa, or plica pathology. Patellofemoral pain after prolonged sitting is often referred to as moviegoer's sign. These folks are the ones that prefer an aisle seat on a flight to allow them the opportunity to get up and move and stretch out more frequently. Moving more in the direction toward patellofemoral instability, let's talk first about the distinction between subluxation and dislocation, which is sometimes really a pretty subtle difference. But a subluxation involves less trauma to the soft tissue restraints of the patellofemoral joint. The amount of displacement of the patella is less, so it may be thought of as a partial dislocation. But the biggest difference is that a subluxation self-reduces immediately. It's more of a quick slip out of place, and it usually occurs in patients with less bony restraint to instability, so sometimes they have a really shallow trochlear groove. In contrast, a dislocation involves more significant lateral movement of the patella, and it typically involves more damage to the soft tissue restraints. So the distinction we just talked about with subluxation and dislocation is really just one of nomenclature and what you're calling it. The important clinical distinction that needs to be made is whether we are dealing with a traumatic instability or an atraumatic instability. The biggest difference here is that patients in the atraumatic group have congenital alignment abnormalities that predispose them to having instability problems. These abnormalities often involve a shallow trochlear groove or a patella that's positioned proximally or laterally, making it susceptible to dislocating with less force than a person who has normal alignment. So people in this atraumatic group are at a greater risk for future dislocations, as well as dislocations on the opposite side, because that bony alignment problem that they have is going to be bilateral in most cases. The first dislocation for these patients will often occur late in adolescence or in the early teen years. The injury is often more of a low-energy injury, perhaps even occurring during ADLs, such as twisting to get out of a car. And because these individuals have alignment issues that allow the patella to dislocate more easily, they often do not have much soft tissue damage and resultant swelling, particularly if it's not the first time they've dislocated. On the other hand, if we talk about traumatic instability, this is more the case of a person being in the wrong place at the wrong time. They have normal alignment and their patella is aligned normally, but they sustain a specific injury mechanism that forces the patella laterally to the point that exceeds the strength of those soft tissue restraints. It's more of a traumatic mechanism of injury, often involving a twisting mechanism with the knee in nearly full extension. Sometimes they self-reduce right when the knee is extended, but sometimes an external force is needed to reduce the patella, and occasionally they even present at the emergency department needing to still be reduced. But typically, once they get past that initial stage and can straighten their knee a little bit, it pops right back in. Some of these patients might experience future dislocations if the soft tissue restraints don't heal well to provide stability in the future. But the difference here is that the injury caused soft tissue damage, which leads to the future instability, compared with patients who are in the atraumatic group, where they also had alignment abnormalities that make them more likely to have recurrent dislocations. So compared with meniscus tears, ligament injuries, OA, patellofemoral instability is really less common than these other knee conditions. The reported incidence is 6 in 100,000 overall, with a higher incidence among adolescents and females. The dislocation often occurs when the knee is near full extension, and this makes sense as there's less contact between the patella and the femur as you approach full extension. Often the person is externally rotating their upper body on a planted foot, which draws the patella laterally. A valgus force or alignment can also place added stress to the patella in the lateral direction. So as we mentioned in the previous slide, predisposing factors include patella alta, a small VMO muscle mass, and a flattened shape of the trochlea and or patella, which provides less static restraint to this joint. After the first instability episode, the likelihood of future dislocation is increased if the medial restraints, which we kind of refer to that collectively, it can be the MPFL, which is the medial patellofemoral ligament, or the medial retinaculum, has been torn or stretched to the point where it can't effectively tether the patella and restrain against lateral movement. Or maybe the person has bony alignment changes, such as patella alta and lateral patella positioning, so they're at a higher risk for future dislocations. Remember that patients with bony alignment abnormalities are often at risk for instability on the other knee too, as these present bilaterally. Moving toward patellotendinopathy, or jumper's knee, that's the development of changes within the patellar tendon that leads to pain and decreased function. So high forces placed repetitively through the tendon, as is seen in basketball, volleyball, and other sports involving a lot of jumping, can lead to this condition. It is estimated that as many as 15% of athletes will deal with some degree of jumper's knee at some time during their career, and the incidence increases as high as 50% when you look at elite athletes in basketball, volleyball, and jumping events in track and field. All of these involve a large volume of high-impact ballistic loading of the extensor mechanism. As with other tendinopathies, it begins with inflammation of the tendon, but eventually leads to structural changes in the tendon, thus the progression from tendinitis to tendinosis. The key to effective treatment is early identification and intervention to prevent progression to the later stages of disease. Cases caught in the early inflammatory phase usually resolve within about 3 to 6 weeks of effective treatment. Patients with jumper's knee often complain of a dull ache, ranging from to maybe even an occasional sharp shooting pain that's directly underneath the patella. This nearly always presents right at the proximal portion of the patellar tendon, where it inserts to the inferior patella. So if you palpate or ask them to localize their symptoms, it'll usually correspond with this region. The pain worsens with jumping, landing, and running activities. Progression of the disease can be noted by when the symptoms are present. So if the symptoms are only present after activity, but they're absent during the activity, the patient is still relatively early in the disease process. But as the disease progresses, then the patient starts to begin experiencing pain when they're first starting their workout that goes away after warm-up and then comes back afterwards. That would be a stage 2. Then stages 3 and 4 are when the patient has pain all throughout the activity. At the beginning, it doesn't go away. After warm-up, it sustains through the activity, and then they have pain afterwards. The difference between stage 3 and 4 is that stage 4 patients, their performance levels are affected by the pain. Some research has suggested that focusing on increasing hip extensor strength is an important part of effective treatment. So if you think about it, an imbalance here could lead to overuse of the quadriceps and overloading of the extensor mechanism. So that's often a big part of the treatment. Also, tightness of the extensor mechanism, hip flexors, and even hamstrings could lead to increased tension through that musculotendinous junction. As with other overuse conditions, activity level plays an important role, particularly when it comes to high velocity loading through the tendon. So a sudden increase in running, jumping, and quick changes of direction can be a contributing factor, making a good graduated preseason conditioning program an important part of the prevention. So let's move on to meniscus tears. Meniscus tears are best thought of as two main categories, degenerative and non-degenerative tears. Degenerative tears typically affect patients over the age of 40, where long-standing changes in the quality of the meniscus eventually lead to a symptomatic tear. The quality of the tissue surrounding the tear is less, often appearing frayed. And as we've discussed with the disc derangement in the lumbar spine, degenerative tears to this type of tissue is a normal consequence of aging. So imaging studies will often reveal meniscus tears in most people over the age of 30, yet all of these will not be symptomatic. So it's really important to correlate your patient's symptoms and physical exam findings with MRI findings, because if it's a middle-aged person or older, most MRIs will show a meniscus tear, and that may or may not be the source of their problem. One exception to this age group guideline is young athletes who spend a lot of time in deep flexion, such as wrestlers, baseball or softball catchers, and even volleyball players. Degenerative tears can occur in this specific population of younger athletes, so don't write a younger person off just because of their age. You have to look at their activity. Medial meniscus tears are more common than lateral meniscus tears in this degenerative category, and it's most likely related to the increased weight bearing that goes through the medial compartment of the knee. Moving toward the non-degenerative category, this is more of your acute meniscus tear. So prior to the injury, the meniscal tissue is healthy. These tears commonly occur with ACL tears too, so be sure to test ligamentous stability whenever you suspect a non-degenerative tear. With meniscus tears, location is very important for you to help understand the healing potential of the tear. And by now you're all familiar with the red, white, and the white zones going from the periphery to the more central part of the meniscus. And you know that peripheral tears have a better healing potential due to the better blood supply that's available in the peripheral third of the meniscus. But another factor with the location that you want to consider is medial versus lateral, and also whether the tear is located in the anterior horn, the middle third, or the posterior horn of the meniscus. The presentation and behavior of these tears vary slightly depending on the location. Most of the degenerative changes in the meniscus actually occur in the middle third, so this is the most common location for meniscus tears to happen. Anterior horn tears tend to be symptomatic when the knee is in a fully extended position, because that's when that part of the meniscus is loaded. So patients with moderate to severe arthritic changes can often get a posterior horn medial meniscus tear, where because of the joint space narrowing that's happening with the OA, it forces that part of the meniscus to kind of extrude out of the joint. By understanding the mechanics of the knee, you can really better appreciate the positions that will further aggravate the symptoms, and that'll help you both for diagnosis and treatment of these patients. As we've discussed before, the classic presentation of a meniscus tear is medial or lateral joint pain and tenderness to palpation. It's often accompanied by an effusion and symptoms of catching and clicking or even locking. End range of motion is often painful, and a loss of range of motion is also quite common. With degenerative meniscus tears, there may also be arthritis or joint space narrowing, as we discussed earlier. Treatment for degenerative tears either involves conservative treatment or surgical excision of the damaged portion of the meniscus. These degenerative tears are not really amenable to repair because the viability of the tissue around it is just not good quality, and there's poor healing potential. The presentation for a non-degenerative tear is quite similar, but the patient can usually identify a specific injury that corresponds with the onset of their symptoms. Treatment of a non-degenerative tear may include repair, and that just depends on the size and the location of the tear, as well as the quality of tissue surrounding the tear. They want to make sure that if they're going to do repair, that there's a good likelihood for healing with good tissue quality. In terms of epidemiology, meniscus tears are quite common, and over half of individuals over the age of 45 will have a symptomatic meniscus tear at some time. Over 1 million scopes per year are done for meniscus tears, so this is a really common problem. They're more common in males than females, with a meta-analysis by Snooker showing a nearly 3-fold increase risk for males versus females when you're talking about degenerative tears. As discussed earlier, ideal treatment will depend on the quality of tissue and blood supply to that area, so the age of the patient, the type and location of the tear will all be factors in that decision. Moving to the articular cartilage side of the equation, articular cartilage lesions can actually be quite common, with an estimated overall incidence of about 4 to 5% in the general population having a full thickness defect. Now, are all of these symptomatic? No, definitely not, but studies looking at elite basketball players show an incidence much higher, almost 40 to 50%. There are some that feel that many asymptomatic lesions are being treated now just because they're being identified more with the prevalent use of arthroscopy. And arthroscopy is great. It allows for really good visualization of the whole joint, but it's allowing us to detect these. And the question is really, is that the source of the patient's problem, similar to what we talked about with seeing meniscus tears on MRI. So the difficult question here is which ones require treatment. The medial femoral condyle is the most common location for articular cartilage defects, with about half of them presenting in that area. The underlying cause of articular cartilage injuries is often repetitive microtrauma. Occasionally, a specific injury with a sudden high-impact force to the cartilage can also result in a defect. But another underlying cause is a condition called osteochondritis dissecans, often abbreviated as OCD, and not to be confused with obsessive-compulsive disorder. This condition is where there's a disruption of the underlying bone, the blood supply to the underlying bone, so that causes the overlying cartilage to become non-viable, and then the cartilage can kind of bubble up and eventually fragment off into a loose body. One study of NFL players found that this condition is linked to a higher BMI, and the cutoff in this study was right around a BMI of 30. Seemed to be where the risk became much higher for cartilage defects. So this slide here, talking about ligamentous injuries, is mostly for your review. I know you are all familiar with the 4 primary ligaments of the knee. I'd like to point out quickly that on the lateral side, injury here can either lead to an isolated LCL tear or a more severe injury called a lateral side injury that involves the lateral capsule, IT band, and other structures that provide lateral stability to the knee. A quick review of the grading system is provided here as well, with grade 1 being a stretch of the ligament without distinct tearing, grade 2 being a partial tear, and grade 3 being a complete rupture. But clinically, the important factor is whether or not an endpoint can be felt on exam, and then whether the ligament can provide adequate functional stability. That's what often dictates whether or not patients will require surgical treatment or not. Before we discuss each ligament tear in isolation, combined ligament tears can also happen, with a combined ACL-MCL injury being the most common combination. Many times these combined ligament injuries involve the ACL and then 1 or 2 other ligaments. So you may also hear discussion about someone suffering a knee dislocation, and your first clarification that needs to be made is if they're actually referring to a patellar dislocation, because sometimes they will be talking about a patella dislocation, just call it a knee dislocation. But if they're referring to the tibiofemoral joint, a knee dislocation is anytime 3 or more ligaments are involved. It's typically the ACL and the PCL, and then either the MCL or lateral side being involved. So ACL injuries are usually non-contact injuries. Sports broadcasters often comment that nobody was even near the athlete when they went down. The study by Sigward and Powers found that 70% of ACL tears are non-contact. They usually occur when landing from a jump, when the athlete is somehow off balance or the landing is mistimed, maybe due to even an unexpected change in terrain, like there's a hole in the field, or sometimes they're just bumped a little bit on the way down by a defender and it knocks them off balance and causes the timing to be off on their landing. But quick deceleration and directional changes are also common culprits. The bottom line is that females playing cutting and landing sports are 4 to 6 times more likely to sustain an ACL tear than their male counterparts. And much of the research right now is devoted to trying to understand the underlying reasons for this and leading into how we can prevent this injury in the future. So a patient with an ACL tear presents with at least a moderate effusion. There's a fair amount of swelling in the joint and a loss of end range of motion. So usually there's about a lack of 10 to 15 degrees of extension. They also have a corresponding decrease in quad activations. Sometimes they have trouble firing the quads due to the swelling. They'll often walk up on their toes holding their knee bent. The description of the injury that they give is also really pretty classic. They describe feeling their knee shift, immediate pain with hearing or feeling a pop in their knee, and they're unable to return to the activity, often requiring help to get off the court or field. If these patients go to the ER, they're often given crutches and sometimes an immobilizer until they can be seen by an orthopedist. It's preferable to keep the patient fully weight-bearing and work to resume full range of motion as soon as possible. So you really don't want to do anything that will perpetuate problems with quad activation or stiffness, as deficits in these areas can lead to more problems post-op, as you kind of start at a disadvantage if you don't have full range and good quad activation. PCL injuries are less common, representing about 3% of all knee ligament injuries. The most common mechanism is the dashboard injury, where the tibia is driven posteriorly by contact with the dashboard during a motor vehicle accident. The other common way for a PCL tear to occur is falling directly right onto the front of the knee with the foot in a plantar flex position. Presentation-wise, patients with PCL tears don't present with as much swelling or symptomatic giving way as the patients with an ACL tear do. If the injury is recent, you might observe bruising over the anterior tibia, but in situations where the injury happened some time ago and it's more of a chronic case, the patient may actually complain more of pain in the medial or patellofemoral compartment, because without the PCL providing full stability, there are long-term effects on the joint mechanics that can take their toll on the joint. The patient may recall an injury, but the PCL tear often went undiagnosed, as they can be easily missed. The mechanism of injury for the MCL is valgus stress to the knee. You may have heard of the terrible triad before, and this was first reported by O'Donoghue in the literature as an ACL, MCL, and medial meniscus tear. But Shelbourne and Nitz in 1991 did a study that found that the combination is more commonly an ACL, MCL, and lateral meniscus tear. And this actually makes sense when you think about the mechanism for tearing the meniscus, which involves compression in the meniscus. A valgus force to the knee, which would cause the combination of ACL-MCL tear, would impart compression on the lateral meniscus rather than the medial meniscus. So in clinical practice, I've also seen that the more common combo is the ACL-MCL lateral meniscus. The patient presents with medial knee pain and stiffness, but because the MCL is an extracapsular structure, there's little to no joint effusion if they've suffered just an isolated MCL injury. On the lateral side of the knee, the less serious injury is an isolated LCL tear. This usually occurs when the knee is forced into a figure 4 position, which can happen in wrestling quite often, but it places varus stress through the knee and damages the LCL. As with the MCL, isolated LCL injuries do not cause significant swelling due to their location outside the joint capsule. Lateral side injuries are an entirely different beast. These usually occur in conjunction with an ACL tear, and they're really high energy injuries. It represents a mass disruption of the lateral side restraints, not just the LCL. So thinking back through your relevant anatomy, a gapping of the lateral side of the joint raises concern for traction injury to the common peroneal nerve, and that can lead to foot drop. So vascular injuries are also a concern with this type of knee injury. So this injury is considered a medical emergency so that you can get the patient in to evaluate for any neurovascular compromise. And surgery is usually performed within a couple of days because the lateral structures retract and become more difficult to repair if too much time elapses between injury and surgery. So that's all for right now. Thank you for hanging in there. I know this presentation covered a lot of material, but having a baseline understanding of these primary conditions related to the knee will allow us to spend more time in lab and doing cases during class time.